Welcome to AETCM. Today we're going to discuss a case about a case of fungal pneumonia. Actually, this is a 57-year-old male who was brought to our ER with complaints of progressive breathlessness and productive cough for about past 1 month.
Okay.
So, in initial assessment, the patient was conscious and oriented and was obeying to commands.
Okay.
In the primary survey, the airway was patent and there was no pooling of secretions and patient was able to talk.
Okay.
But patient was having severe breathlessness, work of breathing was noted. And in auscultation, the chest was bilaterally, air entry was bilaterally equal and respiratory rate of 36 per minute was noted. And also saturation was 90% in room air.
Okay. What is abnormal here?
Yeah, the respiratory rate is
Rate
30.
is very high.
And saturation also 90% room
Okay.
air.
Okay.
So we initially we asked for an ABG by that time, and also we had tried to try to give oxygen through mask, but as the patient was not able to tolerate, and we changed it to NAV
Okay.
at that point of time.
Okay.
And in circulation, peripheral pulses were good, and pulse rate of 102 per minute, and BP of 130 or 70 mmHg was not. GCS was full and pupil was equilibrium. At that time, temperature was normal. So adjuncts, the main adjuncts was ABG was taken.
Okay.
ABG was taken and it was showing a pH of 7.41 with PCO2 of 71
Okay.
and bicarb of 44.
Okay.
And type 2 respiratory failure was seen in the ABG, and other than that lactate was near normal but on the higher side.
Okay. But the pH has gone to opposite side, slightly opposite. What else you suspect? Anything else can be there?
Maybe outside hospital treated with Lasix.
Lasix. Potassium is low. Slightly low. That can produce some amount of metabolic alkalosis. Okay. Maybe the reason it has gone slightly towards the opposite side of the pH. Okay. Towards the alkalotic side. Okay. However, it is a compensated this one. Okay.
And ECG was taken, which was showing sinus tachycardia with no significant STT changes were not.
Okay.
But coming to the history, the patient came with complaints of cough with expectoration and breathlessness for about 1 month, and he was admitted in the nearby hospital initially and was in the first time conservatively managed, and later on he again developed the same complaints again after the same and went to nearby hospital, in which it was diagnosed with bronchopneumonia with enstomy and was managed with the antiplatelets and antibiotics and discharged, and later on again he developed the same complaints, and for further care he came to our hospital.
Okay.
So other than that, the comorbidities is a known case of reform from daily smoking. Likely a pack of cigarettes has been taking.
Okay. One pack per
day. And other than that, it's a known case of COPD on MDA salbutamol with tiotropium.
Okay.
And other than no significant history was not, sir.
Okay.
So in general examination in chest there was bilateral Krebs and bilateral wheeze was noted, and bilateral pedal edema was noted.
Bilateral pedal edema is due to what is the reason?
Maybe due to the maybe little bit of cardiac failure.
So cardiac failure is one reason. Chronic respiratory infection, COPD, cor pulmonale, that can induce pedal edema.
But the ECG that was not showing any significant changes.
Okay.
Then that vitals we kept him on NIV with 91% saturation and 25% SpO2 at the rate of 12:5.
Okay.
So we sent with the routine investigations, in which the total count came out to be 14,600 and a CRP of 153. And Procal was negative at that time.
Procal indicates?
Procal indicates bacterial infection. Usually Procal is produced by the thyroid cells. In the condition where bacterial infection is there, it will be produced by the all of the cells in the body. The bacterial load is the Proccal gives the bacterial load and
Increased Proccal means increased bacteria.
load. It can we can titrate the antibiotics according to the Proccal.
Okay.
And RFT was came to near normal, and other than that we was also sent for the cardiac enzyme as he was having, they were given a history of enstomy.
Okay.
It came out to be normal, probably also 160.
Okay.
And electrolytes also was in the near normal lines, and
Okay.
phosphorus in the lower
Okay.
range.
Okay.
Again we sent for chest x-ray as he was having severe breathlessness.
What is the finding?
Chest x-ray was showing multiple patches, bilateral densely infiltrated multiple patches, more like a rounding opacities was noted, sir.
Okay. Okay.
Round opacities were not.
Okay. So that is multiple lung infiltrates. Okay. So multiple lung infiltrates. Everywhere it is there.
Yes, that's not.
Okay. So what is the differential diagnosis? Is it cardiac failure?
Cardiac failure, sir, the X-ray pattern will be a little bit. This is a model
Same
size of
patient can have cardiac failure.
Cardiac
Only
failure.
thing against that is a normal heart. Heart is not dilated here. So that is mostly against cardiac failure, and BNP is not very high.
high.
And other than that, other than cardiac failure, what are the differential diagnosis for this X-ray?
Sir, pneumonia.
Pneumonia, bilateral pneumonia due to?
Due to bacteria.
But procalcitonin is normal, no?
Okay. Then other than that, fungal pneumonia is other.
Most common thing is viral pneumonia. Viral pneumonia, then fungal pneumonia.
And then we also were also suspecting TB at that point of
TB
time.
is one important diagnosis. Okay, TB, fungus, and viral pneumonia. Okay. So how many days history of fever?
So he was having on and off fever since the past 1 month.
1 month means mostly towards fungus or TB.
TB.
Okay, you have to write whether it is fungus or TB. Fungus or TB. Okay.
And further for clarity, we went again with the CT chest. HRCT chest was taken. So HRCT was showing multiple cavitating lesions were noted, sir.
Okay.
So multiple nodular confluent areas of consolidation.
If it is cavitating pneumonia, if it is short history like 5 days, 6 days history, or if the patient is coming from another ICU, that is hospital associated infection. What is the likely organism here? If it is 5-6 days, or a patient is having hospital acquired infection, what is the likely organism which can produce cavitating pneumonias bilaterally?
Klebsiella.
It is Staphylococcus. Multiple area staph. Okay. Klebsiella mostly they have single focus or 2 or 3 focus, but here throughout the lung field it is there, then it is staph. But whereas in tuberculosis and fungus both can produce cavitating lesions. Okay. So TB and fungus is still there.
So we went again with the further investigation, including sputum culture, blood culture, and we started him on empirical antibiotics, and also, and by that time we got the result for the same. Blood sputum culture was showing initial sputum testing showed Acinetobacter.
Okay. Acinetobacter is hospital acquired infection mostly.
One was sensitive to doxycycline.
Okay. Then
Later sputum culture came in.
Okay.
And in sputum culture, Aspergillus fumigatus was seen.
Okay.
And it was sensitive to fluconazole, voriconazole. And we started him initially itself because of the picture. We started him on antifungal with voriconazole.
Okay.
And the sputum culture when came in, it was also sensitive to voriconazole.
Okay.
And we continued the same. And other than that, we continued the NIV also.
Okay.
And
what is the IgE levels?
IgE levels was 1100.
Slightly on the upper side. ABP, allergic bronchopulmonary aspergillosis, that will be very high. Okay. Any other fungus test you can do?
KOH.
KH preparation is in the sputum. Galectomen,
Galactomannan.
that can be done to rule out fungus. Already sputum shows fungus, then we have to treat it. But in a patient who is not having this much findings, if the fungus is positive in sputum, sometimes it can be contamination. Local commensals, all these things. But here the patient is having chronic history, cough, multiple lung shadows with fungus positive, then probably we have to treat it as fungal pneumonia only. Okay, but Acinetobacter is also positive. So how do you treat both these things? Because now we don't have any evidence which one is producing this problem. We can only clinically assess. We need to have bronchoscopy and bronchoscopic washing is required. So what treatment you are giving now?
So initially itself we started him on empirical antibiotics with meropenem, with voriconazole, and later on when Acinetobacter culture came in, we started him on doxycycline also.
Okay.
And his CRP and also was in the higher range initially, and it began to come down as he continued to stay in hospital. And later on, we changed the antibiotic from the meropenem to linezolid and Magnex.
Okay.
And
What is the advantage of linezolid over meropenem?
as he is having a hospital-acquired infection also, more coverage.
That will cover only MRSA. Other than meropenem covers most of the organs, including your Acinetobacter. But linezolid adding to the regime may be covering MRSA. But we didn't get any MRSA here. Only thing is we have only sputum culture and sensitivity. Sometimes we don't get full organism only culturing the sputum. We need to have bronchoscopic lavage and do the culture. Okay.
Yeah.
How is the patient now?
So patients clinically patients counts are decreasing. Total counts are decreasing. CRP is also on the decreasing range.
Okay.
Still continuing on the NIV support.
Okay.
Most probably, as the lung was showing increased amount of lung destruction damage, he may need further NIV support and prolonged hospital stay, and later on he may need long-term oxygen therapy at home.
What is the albumin level in this patient?
Albumin level initially was on the normal range, but later on his albumin level began to decrease.
Why it is decreasing?
As patient is continuing with the voriconazole injection. Voriconazole is protein.
Any patient who is admitted in your ICU, why their albumin is reducing? One is they are not taking adequate diet. That is very important. Diet is compromised here. Second thing is, when there is sepsis, what happens? Vascular leak. What is vascular leak?
Leakage of the
blood vessels. There will be small opening, and through that your plasma will leak out. That contains a lot of protein, albumin. So that produces hypoalbuminemia. What are the problems of hypoalbuminemia in your ICU? This patient's albumin is only 1. What are the problems?
It will cause there the patient's body will swell up, means anasarca.
Anasarca body, like you can get pedal edema, anasarca, ascites, all these things. Second thing.
Then patient.
What is effective circulatory circulation? Effective circulation.
The total circulation.
So you have, for example, you have 5 liters water in your body. 5 liters. Okay. You have 5 liters water in your body. Okay. For example, 5 liters water in your body. So some amount will go to intravascular compartment. Some amount will go to extravascular compartment. So maybe like some 2 liters will be in your intravascular compartment. That 2 liters is held there by what? What is the force which holds this fluid in your intravascular compartment?
What
is that pressure called as? Oncotic pressure. So when the albumin is good, this amount of fluid will retain in your compartment, intravascular compartment. When albumin goes down, like here sepsis, vascular leak, albumin is reduced. What happened to intravascular volume?
Intravascular volume reduces. Extravascular volume.
So when the intravascular volume reduces, what happened to the internal organs? See, your internal organs are perfused well. Like for example, your kidney is well because of your blood vessels are having some pressure. Okay, because that contains volume. Now intravascular volume is lost. So kidneys or any other organs, their perfusion will be
reduced.
So intravascular volume that is dependent on the perfusion of the organ is dependent on the intravascular volume and intravascular pressure. So the perfusion of internal organs will be compromised. That is the first thing. Then most of these antibiotic and antifungals you are giving, like meropenem for example, antibiotic, how they are transported?
Through protein bound form.
So they bound with albumin. Okay, that will be taken to the site where there is a problem. Okay, so if the albumin is not there, what will happen?
It won't be reaching
It will not be transported to area, and your antibodies produced in your body, antibiotics you are giving, everything will be bound with albumin and go to the target site. Now albumin is not there, so what is the problem?
Antibiotics and the antibodies won't reach the
They
target
won't
site.
reach the target site, they just go through the kidney, that's all. So to prevent that, any patient who is admitted like this, if you are giving very high cost antibiotic like meropenem, if we are not correcting the hypoalbuminemia, there is no point in giving that much high dose or high quality antibiotics. You correct the albumin, we know that it is costly. Each vial cost around 5,000 rupees, but if you are not giving albumin properly, then antibiotic will be waste. What are the other ways you can correct the albumin?
We can IV albumin is the one
Most important. So that is very costly.
So then we can give orally. We can give egg whites which contain.
Okay, so egg white is the most important. Okay, so there are some preparations available, but most important albumin is egg white albumin. So that has to be given. Do plasma FFP contains albumin?
Plasma FFP
Contains albumin. Can we give it in hypoalbuminemia?
No.
It is not recommended. Okay, so many doctors give FFP for this. Many doctors give FFP, but that is contraindicated, not recommended, because that is a foreign product produced by some other person's body. There are a lot of adverse effects can occur after FFP transfusion. So for this hypoalbuminemia, we should never give FFP. We should only give either IV plasma, IV albumin or egg white or some other commercially available preparations. That's all required. How is the patient now?
Patient is still in our care, and as the counts are coming down, we are mostly expecting him to be shifted into ward care for further
So this is a fungal pneumonia. Fungal pneumonia is mostly due to what we are getting in aspergillus or other types of fungus. It occurs in which type of patients?
Usually it occurs in immunocompromised patients, or else in neutropenic cases, or else high long-term steroid use, and can also occur in condition like COPD also.
So diabetic patients, steroid use, cancer patients, HIV patients, all these things. Fungus is very common. Fungus looks like tuberculosis only. That is the only issue. It always resembles tuberculosis. That is also chronic inflammation. This is also chronic inflammation. Both occur in immunocompromised patient. So that is both will resemble like same. Okay. Thank you.
Okay, thank you.